Rahul. I am Lisa Biggs. I am an assistant professor in Africana studies. I work with Rites and Reason. I'm not the artistic director, but I am an actor and a playwright and a performance studies scholar. And for about 12 years now, I've been thinking about healing and working with incarcerated artists who are interested in using performance, in particular theater, to stage interventions and to advocate for their own health and for what they call healing within carceral institutions and larger society, which is why I'm up here on a panel with people who are experts in healthcare in a perhaps more traditional sense. So to my immediate left, I want to introduce Cleo Silvers, a lifetime advocate for healthcare justice and equality. She began her activism as a VISTA volunteer in the 1960s in the South Bronx, advocating for the improvement of living conditions to benefit health outcomes. Shortly after, Silvers co-founded the Lincoln Detox Clinic at Lincoln Hospital alongside community members, doctors, and the Black Panthers. Collectively, they penned the Patient's Bill of Rights, a document that appears in every hospital room around the country. It significantly advanced the standards and ethics of patient care and patients' rights in the public discourse, and helped enshrine concepts such as patient dignity, full disclosure, and explanation of medical treatment and prescriptions and their side effects, and the right of a patient to refuse treatment. Now retired, Ms. Silvers continues her advocacy work at Cossett Library in Memphis, Tennessee. Sitting next to Ms. Silvers is Dr. Andrea Pitts, Associate Professor of Philosophy at the University of North Carolina at Charlotte. They are a faculty of the university's Department of Africana Studies, Center for Holocaust, Genocide, and Human Rights Studies, Latin American Studies Program, School of Data Science, Social Aspects of Health Initiative, and Women's and Gender Studies Program. Their research interests include Latin American and U.S. Latinx philosophy, critical philosophies of race, feminist philosophy, disability studies, and critical prison studies. They've taught graduate and undergraduate courses on topics such as carceral medicine, Latinx feminist philosophy, queer migration studies, prison abolition, critical transgender politics, and feminist epistemology. And last but not least, Dr. Catherine Trimbur is an assistant professor of medicine at Brown University with firsthand knowledge of the structural racism that pervades the academic health system and sickens its patients by virtue of her role providing care to patients exiting the carceral system in partnership with community health workers with lived experience at the local academic residency clinic in South Providence. Please join me in welcoming our esteemed guests to the stage. So thank you all once again for joining all of us on stage here. The opportunity to talk about healthcare systems, structural violence. This is such a pressing topic today. It's something that you all have been, work that you've been deeply embroiled in for years and years, decades. I was just wondering if you could, each in your own words, share with us how you realized that the system was working as it was designed, that it was broken, why this work is important to you, how you got started.
So thank you, and thank you so much, everybody. As a VISTA volunteer in 1966, which is when I became a VISTA volunteer, I was just a nice kid, pretty much out of high school. I had a little job, and my mother had told me that in order to be a broader human being, individual, that I should travel the world, and that I decided, because I didn't do well my first semester in college out of high school, that I probably needed to go and see more and broaden myself as a human being. And I was working as a waitress. I got home. It was midnight. I was working 11 to 7 in the morning. I got home in the morning. There was an ad on TV that said, join Vista and see the world. By the way, Vista was the domestic Peace Corps, so that everybody understands what we're talking about. This is volunteers in service to America. I said, join Vista and see the world. So I was like, okay, fill out the application and you could be a Vista volunteer. So I did. I wrote away, please send me an application. This is the government, United States government. And they did. I filled it out. And in a couple of weeks, they sent me a letter, told me to come to Washington because I'm a Vista volunteer, and that what clothing to bring because you're going to go for training, which is fine. I went there, and Peter, Paul, and Mary were singing. I'm just telling you what really happened. And then they dropped me into a very, very poor community. Well, they first send you to Pratt University in Baltimore for training. And I did this training with this man named John Coe, who was a follower of the gentleman who did all of this research and all this work in Chicago. And my husband will tell you remember what his name is. Saul Alinsky. So you guys know. So the Saul Alinsky method of organizing is you go door to door, you talk to people, and you listen to what people's needs are. So you don't go into the community and tell them what the needs are. You find out from the community. And boy, I learned that. So that was my organizing technique. And then they said, now we're going to send you to your assignment. They dropped me down in the middle of the South Bronx. I'd never seen a Puerto Rican before. I'd only seen Black people and white people, and I'd never heard people speak Spanish, okay? So I immediately knew I had to figure this out if I'm gonna be here. And the only thing they said is you gotta help the people. That's all they said. So my first couple of days there, I was like, oh, I see a lot of kids and they're running around, they're bad. So this is so serious. And so me and my partner, Paula Bowers, we went to the elementary school, and we went to the principal's office, said, we're Vista volunteers, we're here to help. And this man said, these kids are nothing but garbage. Their parents are nothing but garbage. They're only going to be garbage pickers. And that you lovely girls that have come here, I don't even know why you're here. So, but I started to work with these kids. We started to work with these kids. And all we found out was that these children needed somebody to hear them. They were not just disruptive in the school. They needed somebody to listen to them. And then in order to work with them, we decided we got to go see their parents to find out what's happening in their lives. We went to see their parents. There are a couple of things. Their parents had problems because the buildings were horrendous. The housing conditions were so bad. And they led to very bad health conditions as well. So now we're getting to the healthcare question. People had all kinds of illnesses. They had the flu, they had tuberculosis, they were addicted to drugs, they had all these problems. Then, and I hope I'm not taking up too much time, Lisa.
No, it's okay.
Then we started to accompany the parents to the welfare office, which was terrible. And people used to come into people's homes and see if there was a man in the closet. All this stuff was going on. We had to fight that. And all these problems getting people food and enough money to feed their children because unemployment was so high, which also contributed to the health conditions. Then we had to accompany people to the hospital. And this is where the real problem came in. Accompanying people to the hospital with serious illnesses or something wrong with their children, and finding that in the Lincoln Hospital emergency room, the wait time was up to 72 hours to be seen. There was no such thing as triage. They were speaking to people who did not speak the English language in English, so that they had to use their children to translate serious illness questions to them, instead of having somebody who could professionally talk to them, or somebody who could understand what they were talking about as adults. There was blood on the walls. The paint was peeling off. The hospital conditions were so bad. There were not attending doctors there, but there were interns and residents seeing the patients in the clinics everywhere. And after a while of accompanying people to the hospital with all these different illnesses, I was like, who's responsible for this stuff? And then came in this group of pediatricians, young interns and residents that wanted to help the community. And they came in and started to really get in my ear about why this was going on. They came in from Albert Einstein College of Medicine. Now, the workers in the hospital started telling me about Albert Einstein College of Medicine, who was running the place to teach the interns and residents and not to take care of the patients. And I'm like, oh, this is a bad situation. So we got to look to Albert Einstein College of Medicine to find out how to do this, to find out what we need to do. So there we are. And I passed it. I'm sorry.
Thank you. No, that was great. Thank you. That's what we want, the personal story. So how do you enter into this? How do you become engaged in this work? Yeah.
First of all, let me also extend my thanks to you all for being here. Also, those folks on Zoom, the Center for the Study of Race and Ethnicity in America, Dr. Rahul Vanjani, and everyone else who's brought this event together. It's a real honor, and it's an honor to be on stage with you all. It's a dream of mine to be able to meet Cleo Silvers and to be able to share conversation and space with her, because you're a legend in my life. So thank you. Okay, so my story is I'm a pretty much a scrappy mixed kid from Florida who comes from a mixed race, mixed ethnic background. So my father is a white settler from Virginia, also a hippie and anti-authoritarian in his own way, also a drug and alcohol user. And my mother is a migrant from Central America, and we come from El Salvador, Nicaragua, and Panama on that side. And so my family on my mother's side grew up during the kind of desegregation era in Miami and South Florida, and I'm a kind of product of that. I think 2 points of reference in terms of how I come into the question of structural violence in healthcare is, one, as someone who witnessed my mother and my family negotiate sliding scale clinics, child welfare services, drug and alcohol addiction, lack of counseling and resources for interpersonal violence. And so just from a young person's perspective, seeing things that didn't add up, that pissed me off, and that, just couldn't really be explained in any way that was fulfilling, and also trying to understand how to make my own way in that. And that's not without the truth of the love and the stability that I had from my family, but there were also things going on that, again, didn't add up and I didn't have a language for. And I also certainly wasn't college bound. So those were things that I think I had a lot of love and support from some key mentors in my life who really turned that around. But so that's one point of entry, of kind of realizing that a lot of the services, for example, for dealing with interpersonal violence, aren't really set up to think through interracial relationships and what that means when an abuser is a white man abusing a brown woman or a black woman, for example. And so how do we see services that are actually responding to those kinds of dynamics? And I know at the time, I didn't have those fully formed questions, but I knew that there was gaps and there was things that should have been there that weren't. So that's one point of entry, and these are both non-academic points of entry. The second is actually when I, and I could tell that story later if folks are interested, which involves jazz music, in fact, which we were talking about jazz music. So I ended up going to college only on a music scholarship to play music. So in fact, yes, yeah. So we'll talk jazz later. Wow. Yes, but one college I applied to, one college I got into, and then I ended up having some strong support in getting into a graduate program. And it was when I was a graduate student that I ended up doing work actually at Riverbend Maximum Security Institution in Nashville, Tennessee, which is a maximum security prison. And there was a program facilitated between a professor of mine and a group of incarcerated men on death row. And what I started to learn from this group. So what we were initially doing was reading texts together. So we read some philosophy texts, we read Plato, but we were also reading Assata Shakur. We were also reading Toni Morrison's jazz. We were also reading, so we were starting to kind of expand the philosophical terrain, we might say, and the practical stakes of what it meant to be in community together. And so we started doing advocacy groups and the group I worked with was called a medical subcommittee. And what that was an opportunity to figure out how to advocate for the folks who were incarcerated from the outside to ensure that they were to try to kind of broadcast and get attention when there was medical services that were not being provided on the inside. Also, I remember one of the terms that came from this subcommittee was I was hearing a lot of the guys talking about what they were calling intentional misdiagnosis. And so that sparked an interest and said, this is designed to actually keep people sick. This is designed to put people back into their cells or to refuse the kind of demands that people are making in this context. And so as I started to scratch the surface of that question about what it would mean for a provider to intentionally misdiagnose a patient, because I had studied bioethics before that, but nothing was along the lines of this kind of emphasis. And so I think at that point, I realized there's much of what I had even learned from my traditional philosophical education was ill-equipped to address this. And so at that point, through working with this subcommittee and then through kind of further engagements and dialogues and other kind of activist projects along the way, I started to realize, okay, there's a way to do this differently. There's a way to think about maybe liberation medicine or, other frameworks, social medicine, other frameworks to think about how the way in which healthcare gets offered can be very much consistent with colonialism, very much consistent with racialized capitalism. And so those were the kind of well springs for now giving me language to think about those things that so many years before I did not have. So those are just some entry points.
Thank you. Catherine.
Okay. I also want to say thank you to everybody. It's wonderful to be here having this conversation. As Andrea said, I also just feel incredibly humbled to be up here on the stage with you all. And Cleo's work really informed a lot of my training in residency. So it feels quite moving to hear the stories from you that we read about, and that really informed how I became a doctor. So I want to thank you for allowing me to be up here with you. And I also think it's so interesting how our stories of how we sort of started to think about structural factors and structural violence are both personal and professional. And I think that I was raised in a tradition of Marxism, and so was really sort of taught about structural factors from a very young age. And I was lucky enough to come here undergrad and was also raised in Africana studies. And so I think, from a young age, I was sort of exposed to thinking about the ways in which structural factors shape how we move through the world. And if you forgive me, I'm going to read something so that I share with you.
Do it.
Thank you. I appreciate that. So I think I was, informed and sort of prepped for this. But the thing that really sort of stood out in my mind as we started to prep for this panel was in my early 20s, I was given an opportunity to work in New Orleans in the aftermath of Katrina. And there I was able to do oral histories with community-based organizations about the rebuilding effort. And this work to me really laid bare the deeply rooted historical legacy of structural barriers to Black and Brown communities, specifically in accessing the resources both within healthcare but across the spectrum of life that were necessary to rebuild differently. And what was remarkable was observing the attempt from grassroots folks to rebuild differently, to restructure, and to truly heal. But these thoughtful, informed, and community-based solutions were met with bureaucratic structures, as Dr. Biggs says, doing what they were meant to do, which is to allocate and direct resources to certain communities and away from others. As many of you probably know, in the aftermath of Katrina, Charity Hospital was closed. And so in the midst of this wild devastation of a really important and incredibly strong community, the second oldest continuously operating public hospital in the country was closed. And it wasn't closed because the community called for improved healthcare or improved facilities, but the natural disaster of Katrina created an opportunity to accomplish what some had really wanted to do for years, which was defund and reduce material resources to this public hospital. Louisiana State University and the VA both called for a plan that would demolish the old building and have it replaced by a massive medical center jointly run by the university and the government. The University Medical Center of New Orleans, as it would be called, was to carry on the mission of being a safety net hospital for the and underinsured, mostly Black community that Charity served, but with the new expanded capacity to accommodate privately insured patients in a brand new state-of-the-art facility. On the surface, the explanations were easy to swallow if one accepts the framework of a capitalist for-profit health system. That Charity Hospital was old, it was losing money, and there would be restructuring that would be better financially and for the community. Yet I think, as we hopefully will make clear today, accepting that framework is really an anemic attempt to understand what factors are truly at play. So community organizer Jacques Morial, who worked in New Orleans for most of his life at the time, explained, quote, "There is a perception that UMC wasn't built for the population that Charity served. That's because there's no urgency to either replace what Charity represented or rebuild the trust that those who relied on Charity had in it," end quote. The knowledge, the expertise, the intergenerational awareness of the material and symbolic nature of Charity's hospital existence was dismissed in the conversations about rebuilding. Charity Hospital, for the historical context, Charity Hospital was the only comprehensive acute hospital to admit Black patients in Louisiana during the Jim Crow era and throughout the Civil Rights era. After Charity Hospital was closed, so Charity Hospital had 160 psychiatric beds and the new medical center had 60. And that really sort of, I think, made clear where priorities were. A New York Times article almost 10 years after summarized the concerns, I think, quite aptly. Some question whether University Medical Center will be sufficiently focused on the requirement to provide free or reduced cost healthcare to all indigent and uninsured patients, while it is trying to build what its leaders called destination programs to draw more privately insured patients. I think what's important here is that the goal existed prior to Katrina. There had been a prior desire shared by both the academic health institutions and many in government to change the state's healthcare system. Charity had served as a site of learning for many generations of medical trainees in New Orleans. The trainees who had learned on the backs of the safety net hospital for generations would be fine. Academic institutions would not let the learners lose in this. Enough patients would have to come to the new medical center for medical students and residents to learn from, but there was no parallel bureaucracy or system ensuring that the people who relied on the hospital would also land on their feet. nor, and I think this is the important part, is nor that the importance of charity to the community was weighed in the decisions. The argument here is not about whether charity should have been rebuilt as it was or changed or absorbed into the new medical center. It's about the process of decision making and the locus of power to exercise control. And the majority of people in the position of power to make these decisions were not part of the community that really understood the historic nature of Charity Hospital. And this was, watching that process was in such juxtaposition to the grassroots community organizing that really honored and respected and incorporated the expertise, the knowledge from within the community. And I think that was, it was so clear to me that there were two sort of separate ways of moving through the recovery and the rebuilding process that I think was, this was right before I started medical school. And so I think it deeply shaped how I understood the role of medicine and medical centers within the community in general.
Thank you. We've gotten a lot of, I think, context. And thank you so much for sharing your individual stories. Something that we talked about, though, the other day was the importance of telling a larger, moving from the personal to kind of a historical narrative. And so I was wondering if you each could take just a couple minutes to talk about the how we got here, meaning the big story. So settler colonialism, anti-Black racism, and then, of course, the issue of the medical training itself, this idea of intentional misdiagnosis that you've referenced, I think is, unfortunately, it's at the heart of a lot of Western medical thinking. But I don't want to put words in people's mouth. That is my opinion. So I was wondering, maybe could you, where do we want to start with? Anti-colonialism? Yeah, let's start there. And then, this, that, the other, it's all happening at the same time. So it's not like a beauty contest here. So.
Thanks, Dr. Biggs. So when we were brainstorming a lot of this, we were talking about, okay, how do we, if we're going to try to frame structural violence in academic residency clinics or healthcare center or academic health centers and so on. One obvious touch point is thinking about universities as themselves part of a settler colonial process. And so I must admit, I'm not going to be as well versed as folks in this room. So the narratives I'm about to give, if I'm going to try to give them locally to the extent that I can, and I invite you to, correct, add, build, revise whatever needs to occur during the Q&A, because I thought there might be a few ways to try to narrate this place, which again, I'm not the expert on, but these are just some of the resources that I found to try to locate myself here. One will obviously sound familiar to you, which is like the Roger Williams story of settler colonization in this place. And of course, that would include the detailing the devastation, and I'm going to look at my notes here, detailing the devastation of the Narragansett, is that right?
Narragansett,
Narragansett peoples, from their traditional homelands here in terms of land dispossession, events like the Great Swamp Massacre of 1675, and the detribalization of the Narragansett by the state of Rhode Island in the 1880s, and then of course the long fight of the Narragansett to reestablish political recognition in 1983, or to reaffirm their political recognition in 1983 to the federal settler government. But that, I think, narrative doesn't necessarily tell us a multidimensional story about this place and how health and medicine play a role in terms of decolonization. And so I think another story, and again, these may be folks so again, please, I welcome more conversation and input. Another story might include, for example, practices of indigenous food sovereignty here conducted by one of your colleagues here at Brown in American Studies, Dr. Elizabeth Hoover, a Mi'kmaq and Haudenosaunee researcher whose work includes community-engaged research on the dietary exposures to neurotoxins found in the fish in tribal waters among the Narragansett. Another story might stretch back in time and now trace the life of, for example, Sarah Baxter, an Afro-Indigenous Wampanoag woman who lived and practiced medicine in, is it Lippitt Hill? Is that right?
Yeah, so it's the east side.
Okay.
It's the east side.
All right.
The people who removed the Black and Jewish, Indian, and Italian folks who lived on the east side in that area call it Lippitt Hill.
Okay.
But people who were displaced from there, they're east siders.
Okay. All right. So east side. So Sarah Baxter in the mid 1800s had, by historical record, a thriving business that was based in plant medicines that were likely gathered along the riverbanks of the east side. And that included both native and non-native patients alike. And my source on that is, again, another colleague of yours, Patricia Ruberton, here, whose book is Native Providence. Okay. But again, part of that is also thinking about acknowledging this place and the colonization that's led to now the land grant, the land dispossession, and then the proprietary relations to this place. But I think one thing that I also have learned recently is also that there's been tremendous efforts here by a land acknowledgement working group that has not only sought to try to make that clear, some of that historical information, but also then to urge the university itself to follow up. And so they've made several recommendations. And so I'm just going to put these out as questions, and these are from the recommendations made by the Land Acknowledgement Working Group of Brown University, to ask, for example, if we're thinking along the lines of decolonization and the medical school, one, does, for example, the Warren Alpert School of Medicine acknowledge the colonial history here? Do they follow the educational guidelines? Do they commission and support original scholarship of the indigenous resurgence and survivance of people in this place, including those histories and ongoing struggles and practices and thrivings among Narragansett and other indigenous peoples of this place? Do they mark the space here to honor and memorialize College Hill, for example, as a location and the homeland of the Narragansett peoples? Do they support educational opportunities and access for youth among indigenous peoples in this place to attend the university, to enroll in the medical school, and to continue practicing forms of healing and transforming healthcare practices in this place? And lastly, do they partner with the Native American and Indigenous Studies initiatives here at Brown? And again, these are just prompts, because part of that is to say if the task is to locate structural violence in healthcare, we can start where we are. It's also a question of saying, and I think from what I've seen, that there are a number of incredible folks here who are doing this work, and also the task is to create that momentum so that those who are doing the work can be lifted up, supported, and continue to give the platform that they need to do that work. So, yeah.
Thank you. Do you want to pick up the story from there? Yeah. Would you pick up the story from there? I should have put it that way.
Well,
And I am going to have to ask you can you hold your mic too? I know it's so many pieces of paper and things.
Yeah, stuff.
It is.
It's okay.
It's so much stuff. Thank you.
I'm good. So in an attempt to define structural violence and racism, in our discussions, we got to, how did you come about the writing of the Patient's Bill of Rights as one question of how to attack structural violence in a way that might be successful over a long period of time, and so over time, but in the structure itself, try to make a change inside the structure itself. So how we came about it was to understand what are the things that were most violent and most racist in the way that healthcare was being delivered. And that was the questions or the points of sitting in the emergency room with our little table and just saying, this is the complaint table. And people came up to the table, patients in the emergency room, patients from the clinics, patients from up on the floors, the workers from up on the floors came down to describe ways in which the doctors were speaking to the patients. That was disrespectful. So the first point in the patient's Bill of Rights is that a patient should be treated with dignity and respect. So that's right at the core of this structure that disrespects and does not recognize the patient as a human being because it's structured that way. These human beings are not as important or not as good as the people who are supposedly delivering this care to them. Then we spent our time and we collected like up to 4,000 complaints. So those complaints were the patients are being used as guinea pigs, and they are not being given the opportunity to say whether or not they want to participate in research projects, medical research projects. So there's no informed participation on the part of the patient, just research on them any kind of way you want to. There were things like of course we said speak to the patient in the language that they understand, so they will understand their treatment and what is happening to them, and the prescriptions that you're prescribing to them, the medicines you're prescribing to them, and what are the things that can happen to them as a result. Food and water in the emergency room in the clinics. And I have to tell you this story. I'm sorry, you must know the story that at that time, doctors had like a very beautiful dining room. It was a private doctor's dining room. And we're there in the hospital, and of course, administration keeps throwing us out. And at one point, the administration threw us out, and this security guard said, let me help you carry your table back in, Cleo, because I'm a 24-hour kind of dude. I want to be there all the time. And I kept bringing the table back in. So finally, the security guard that threw us out would take the table, take it out, and bring it back. Because he agreed with what we were doing too. So I'm sitting in the emergency room and I'm seeing all these people starving, there's no water available. And I also know that there's this beautiful private dining room for the doctors. I go walk into the private dining room at lunchtime when the doctors are all in there, and I'm like, this place is closed down. So you might as well get out of here until every patient has water and food available in the emergency room in the clinics. That is really violent to people. That is really set into the structure that you should have a beautiful place to eat and drink, and the patients have absolutely nothing in a horrible emergency room or a very badly run clinic. There's so many other ways of being really violent to human beings, including the way that people who are poor and disenfranchised are living, are made to live in conditions where the landlord is coming to get your money and they're not doing anything, and they're allowing their buildings to just deconstruct in front of you, in your life. And also things like in 1969, sickle cell, anemia and sickle cell disease were not recognized diseases. And it was because the Black Panther Party began to go and test for sickle cell door to door in the community and demand that the NIH begin to do research and treatment of people of color for sickle cell that it was even began to be a recognized disease. And that is another way to see structural violence, racial structural violence in the society, where you know already that people, because of what their background is, that they themselves are prone to a disease that you're not even recognizing at all. So those are the kinds of descriptions and much more, as you know, in terms of understanding what the Patient's Bill of Rights included. But that part and the work of the Black Panther Party, the work of the Young Lords, going door to door, just asking people what their illnesses were, and using the important data that they were collecting on a day-to-day basis, on a week-to-week basis, from people who were ill and unable to travel to the building, and kind of edging through the structure to get this work done. And this is what I actually am encouraging you to do, is trying ways to dismantle a structure that is set up to be so mean-spirited and disrespectful to other human beings. So that's where I am on this question of describing structural and racial violence. And hopefully we can have a greater discussion of this. Thank you.
I was just going to say, you're pointing to how, not only how dignity is so integral to people's health, but trusting that the patient is the expert upon what their body needs, what they need. And I'm going to turn to you in just a second to talk about medical training. But was just thinking about how anti-Black racism is at the forefront of Western medicine. I mean, if we think about you talked about the refusal to acknowledge a condition because it is afflicting primarily Black people. But then there's, on the flip side, there's the invention of diseases that only apply to Black people, like drapetomania, which is basically a way of talking about so-called runaway slave syndrome. So God forbid they run away, they must have lost their minds. Drapedome means slave, mania means crazy. So drapetomania was an affliction that only enslaved people could have, as if, the desire, a fever for freedom, was a crazy idea. But that same kind of racialist determinations about who is worthy of care, what kind of diseases people can and cannot get, their ability to feel pain or not feel pain, continue, unfortunately, they were at the foundation of the roots of Western medicine. And then they continue, I think, unfortunately, to influence how people are trained from the beginning. So can you pick some of that narrative up to kind of move us into this, to the 20th century? But also, as a way of really, we're also going to show in a few minutes some pictures of the Young Lords takeover of Lincoln Hospital. I always get the wrong thought. Of Lincoln Hospital, and a short trailer from a really fabulous documentary about the takeover. As soon as that is over, we're gonna, it's an opportunity that we're hoping that those examples can kind of point us into some conversations about what strategies people have relied upon in the past, and so that we can have a really full-throated conversation with you about what's needed right now, and how we might imagine the medical center of the future. So, how are we doing in terms of medical training?
We're trying.
Of course, we are trying. We are trying.
So I'm going to take just a very couple of minutes to sort of describe the residency medical structure, and hopefully set up a lot of actually what drove the takeover. And I think that it's both a really helpful lesson from history to look back at why the Young Lords, both why the takeover was necessary, and what the specific demands were. Because I think that they unfortunately continue to apply today. And I think when you really actually break down what the demands were, it moves to healing. I mean, our conversation has just continuously moved to a place of healing and having conversations about how do we actually heal our patients? How do we create a healing environment? How do we create an infrastructure that doesn't actually make people sicker, but that actually moves us all into a place of truly healing? And I think that there was a lot of love actually behind the takeover, so I want to try and sort of set up both why that was necessary and maybe why some of the principles still apply today. So I'm going to describe, and for those of you who don't know sort of the residency structure, I'm going to just very briefly describe it. And for those of you who do know it, I'm going to ask that you try and just sort of take off the hat of knowing, and just hear what I describe and see if it sort of lays bare, and maybe I'm not going to be this eloquent, but like see if it lays bare something new, a new way of thinking about it. So, residency clinics really began to emerge, hospital-based residency clinics began to emerge in the 1960s when Medicare began funding training programs. And I think one piece that's really important is that in the 60s and again today, that funding is federal funding. So it's taxpayers funding. So when I think about the clinic, that I work at, the taxpayers in the community which I serve pay for a lot of the training that happens. And so the current iteration is hospital-based resident clinics across the country. And I'm going to describe the national data because there's actually very little variation, although hopefully we'll talk about some hopeful models as well. Primarily, residency clinics serve Black and Brown patients. They primarily serve poor patients. They primarily serve patients with Medicaid or who are uninsured. And the structure of many academic medical centers is actually that there's a triage of patients who have either Medicaid or are uninsured or dual eligible, have Medicaid and Medicare, that they actually get funneled to a specific clinic, and that is the residency clinic. Again, nationally, patients of residence clinics, in comparison to faculty practices, so the faculty of, who teach those residents have separate practices, resident clinic patients will have higher rates of chronic illness, worse functional status, more mental health struggles, and worse health measures. So for example, A1C is something that we monitor diabetes with, and nationally, patients of residence have more poorly controlled A1Cs. In addition to that, so that's sort of the picture of the folks that we are blessed with and tasked with caring for nationally. And because I don't have to explain this in detail, but because of structural barriers around access to education and the capital necessary to get through medical training, physicians in these clinics are also unlikely to be from the community from which we serve. So for residency clinics, additionally, the attendings, some residency clinics are structured where they have faculty, like I said, faculty practicing and residents practicing. And within those clinics, studies have shown that the same office staff, when it's a resident clinic running compared to when it's a faculty clinic running, the same office staff will work with more patients and more resident doctors during the resident clinics as compared to the faculty clinics. So just sort of a measure of the burden of the speed with which they need to work and the resources that they have to do the work. Additionally, compared to faculty practices and office-based practices that don't have academic residency patients, are less likely to choose their clinic. So these are folks who don't say, all right, I need a new PCP, I'm going to go there. And it's very rare. The vast majority of patients in residency clinics throughout the country don't choose their doctor. And in addition to that,
the PCP means primary care.
Primary care.
Thank you.
Yes.
Acronyms. Help me. Thank you.
Oh, great. Thank you. And actually that's an important point because a lot of my examples will be from primary care medical residencies, and the data really describes medical residencies across the board. So neurology residency clinics, GI, fellow training clinics. So it's across the board. I'm a primary care doc, so I think primary care is pretty important. And so I think the way that we train and the way that we teach sort of this new crop of primary care docs is really important. And so the sort of burden of lower resources, folks who have more needs, really, falls on residents. And then there's sort of been this move as well, across the country. Residents are becoming more specialized. So in the US, about a third of doctors are generalists, so primary care docs or generalist doctors, and 2/3 are specialists. And that's the opposite of many other countries with similar healthcare structures. So in the UK, for example, 2/3 of doctors are generalists, our primary care docs are generalists. And as a result of that, training in the US has really shifted to focus on specialized care. And so what we have is a real focus of the time that residents spend training is really focused on the inpatient, so time they spend in the hospital and not in the clinic. And so what's emerged is that inpatient resident schedules are sort of the priority, and residents may find themselves the primary care doctor for 80 to 100 Black and brown, underserved patients on Medicaid who have a primary care doctor who is, at best in the clinic 2 to 3 half days a week, and often not at all on certain rotations, and so are going to be cared for by various doctors and not necessarily going to be cared for by their one provider. So we also see really baked into the system and into the infrastructure a lack of continuity, which for many medical conditions is actually at the core of a therapeutic relationship, and the core of healing is to have a doctor who knows you, and to have a doctor who builds your trust, and to have a doctor who gets to hear the stories about your life so that they can appropriately think through how to care for you. And so I think, nationally, what we've really learned is that resident doctors are being tasked with being primary care docs in a clinic where they don't have the time to serve patients. We do have supervising doctors, and again, as with time, what we've found is that the supervising doctors have less and less time to be overseeing. So a study recently showed that that supervising doctors are not required to go into the room. So a patient will come into clinic, see their resident doctor. The resident doctor will then go, we call it precept, with an attending physician, a supervising doctor. And that space is meant to be a check and balance, to listen to what the resident has learned, to teach them, and to come up with a plan and come up with an assessment and plan of what treatment to do. That also takes, as you can imagine, a significant amount of time. And so patients of resident doctors are also more likely to spend more time at clinic. And I think, to what the Black Panthers have suggested, the vast majority of resident clinics don't have food. They don't have childcare. They don't have an infrastructure where this is a place where a 2-hour visit actually works with my life. It's a 2-hour visit where I'm waiting a whole lot of the time. So I think that is sort of the infrastructure that's really sort of built into the both the brick and mortar, but also sort of the educational infrastructure as well.
That's really helpful.
I think that will connect us in an interesting way, because I think I really appreciated, there's different scales of temporalities of violence, if we could call it that, because I think there's really interesting shifts here. So the focus on the patient bill of rights and the kind of immediacy of something like degrading treatment in a clinical setting, a kind of a misdiagnosis or a neglectful situation by a provider, is that kind of enactment of the violence in the moment. And then you've got this temporal waiting it out of the who's available when and how often, which is itself a type of violence. And then there's the slow violence, which is the intergenerational violence, which is itself, slowly attempting to erode populations over time, where we know things like, polluted water and food insecurity leads to multi-generational health effects. And so like we're talking about structural violence in all of these very different temporal scales as well. And I think in a sense it kind of gives us different scopes or parameters to try to also understand that these are connected and that they're very much along, this is a process, right? It's not conflict in the moment, but which for us, for those who are then pushing back, it's a process for us, right? And that's the long game, because it's also putting in the infrastructure to keep people alive and keep people fighting and keep people thriving. Yeah.
And to reduce the harm that's being done to them. We'll cut to, as promised, let's pivot now to looking at the images from the takeover and the video. Let me grab the clicker. Okay. Does every medical school have a resident clinic?
That's an interesting question.
Can you speak into the mic just for the
I
people
was
on
going to
Zoom?
say, there's probably people in the audience who know the answer to this question better than me. I think most do. There are some medical schools that are also separate from, so residency clinics aren't always embedded in a medical school. So for example, like my residency clinic, Montefiore Social Medicine, was loosely associated with Albert Einstein College of Medicine, but we were not the same program. So I think there's associations, but not all of them are together. But if anybody in the audience wants to correct me, I'm happy to.
All right, we'll put that on the list of things we got to find out later. Let's see if I can figure out how to advance these slides. No, you're not. No, wait, you don't need to move at all. Oh, I did something. Ah, there you are.
You gonna tell some of these stories, Cleo?
Yeah, there I am at the table. And as you can see, it was clear what we were demanding, pretty close, and what we were seeing.
Can you speak into the mic so they can hear?
It was clear what we were demanding and what we were seeing at the table here. And that's myself and two patients writing down, or me writing down and narrating to me what their complaints were at the complaint table. This was a 24-hour complaint table. And not only did we take complaints, we intervened in situations in the clinic. In other words, I had to quick learn some Spanish so that I could intervene. And if a child was translating for the parent, I could help in that situation so the child didn't have to do it. And of course, we demand end to racism and free health care for all. That's very important. And that's cut to the chase, but we'll talk about that later.
Okay, wait, here we go.
Okay.
All right, the second image.
So
this is from the Takeover 2.
This is the press conference after we took over Lincoln Hospital. That was the second takeover of Lincoln Hospital, where the young lords took over, and HRUM. So this is the co-chair and the second co-chair of HRUM. And all of these are workers, by the way. Everyone standing here is workers.
From the hospital?
From the hospital or other hospitals, two other hospitals, as Gouverneur and Metropolitan Hospital, as a matter of fact.
Here we go. Okay. And then so we have a newspaper article.
Yes.
In Spanish. Both of these are in Spanish.
This is the hospital belongs to the people. Is that what that says? I can't. Yeah. That's from the Health Revolutionary Unity Movement's newspaper. And it was called For the People's Health. And it was published every week, and we had full-time jobs. We went door to door testing patients for preventable diseases, and we took over things. We had conferences. This is at a conference, trying to bring more hospital workers into the struggle.
And this is you with the N here, isn't it?
Yeah, that's me.
That's you. Okay.
Looking mean. I was
Look at me. That's right.
making those demands. So, and this newspaper really helped us to get other workers involved, and was key to communication. And that is so key to what we're doing today. We have to communicate with each other about what our situation is. That includes students, it includes interns and residents and docs and people in the community. We have to communicate with each other. So this is really a representation of the kind of focus that we use to get people to hear what we had to say and to listen to what everybody else had to say. So,
okay, I'm going to show the trailer now if I press the right button. Yeah. Uh-oh. I think I'm showing the trailer. Can you? Oh, thank God.
This is a story from New York. Not the New York of Manhattan, Broadway, but from
Can you turn
perhaps
up the
the
volume,
toughest
please?
square mile in the city, in the South Bronx.
I was 14 years old when I joined the Young Lords. The Young Lords were a street gang that became politicized by the Black Panther Party.
We became visible as servants of the people. And the people began to understand that New York City offers no solution for spics or niggas or anyone else who's oppressed.
One of our targets was Lincoln Hospital.
That building was condemned 25 years ago. Condemned for rich people and opened up for poor people.
It was a place that you went to die.
Lincoln was called the butcher shop.
Blood stains on the walls, blood stains on the floors.
And there was a rat in the emergency room.
We have seen children get lead poisoning while hospitalized at Lincoln Hospital.
So we felt now is the time for us to say exactly how we're going to respond to the killings of our people.
Our plan was to take over Lincoln Hospital.
We have to begin to stand up as a people, the Puerto Rican people, and say that's enough. That's enough.
We have been asking for changes to take place, and you've paid no attention to us. You've thrown us out of your offices, and you've called the cops on us. Now we're putting you out. We've taken over a hospital. We're gonna run it. You're out, and I will walk you to your car.
We immediately announced that we were not leaving until the city made a firm commitment to build a new hospital.
From El Barrio to Recibo, Palante.
About 1,000 police were en route with high-powered rifles. They had vans all over the place.
If the police came in, it was going to be a bloodbath because the police hated the Young Lords.
We were terrified.
To all who had to hide, I say, Palante.
Power to the people means including people to gain control of their destiny.
The Young Lords were ahead of our time in terms of recognizing that healthcare is a right.
We wanted a revolutionary change to the health system in this country, and we still do.
To all who came before, we say,
Because no oppressor is invincible.
So great. So great. So great. Thank you. So I think the example of the Young Lords takeover, you know, it's a beautiful example of how grassroots coalitions form, cross-racial, cross-ethnic, across all the perceived boundaries that exist amongst us, in order to make a direct impact on people's lives. And I mean, obviously, of the people in the hospital that day, and people should see the documentary, and also definitely ask Ms. Cleo about what happened after that. But because it's a good story, including their escape. It's awesome. It's an awesome story. But one thing that we wanted to talk about also is how the example of Ms. Cleo's work and the Young Lords impacted you two. And I also want to, I'm looking at the time, maybe before we go there, is just to say to the audience, if they have any questions at this point, about anything that we've talked about. What is structural violence? how did we get to this point? Because the next part of what we want to talk about really is like, how do we upend the system that exists and create the medical institution the medical institutions and pathways to wellness and human flourishing that we actually deserve, that we need, right? We're coming out of COVID, allegedly. We're dealing with COVID, right? And Lord knows there's another pandemic on the horizon, in addition to all the other challenges that we're already facing. We don't have a healthcare system that is built to respond to these needs, not comprehensively. Too many people have died, and they keep dying. We keep dying. Yes, sir. Yeah, do you mind? Thank you.
Yes.
You're young, so younger than I am.
Yeah, so in the clip that we just seen, I was really intrigued by the image of the cops showing up following the takeover. So a question that came to mind was, and this was kind of alluded to in some of the comments that were expressed, but what is the intersection that you all see between police brutality in this conversation around structural violence in healthcare, which I would arguably coin medical brutality?
Great, thank you.
Yeah, thank you for that question. So I think medical brutality, medical apartheid, I've been using the term carceral medicine. I think a lot of these are, I agree with you, they're absolutely interconnected. And I think we see that, for example, just as a brief example, through Assata Shakur's autobiography, when she's being after the turnpike and she's being assaulted by the police, she's sustained injuries, she goes to the hospital and she's handcuffed to the bed and being interrogated while she's in the hospital, right? So we see many examples, right? That's just one.
They refuse to treat her for an extended period of time.
Yes,
if anything, they like apply pressure as a way of torturing her to get her to confess to things that she has not done.
Yes.
And to reveal her the connections, the underground, the Black Liberation Army connections. I mean, they refused to treat her for an extended period of time, and she was in critical condition from the moment that they shot her. Yeah.
So we see these examples all over the place, but just to briefly shift back to kind of thinking about the relationship between the institutions, I think part of the, thinking through was also not beyond maybe to try to think through both medical institutions and carceral institutions as actually sharing a lot of features, and not just features that are happenstance, but features that are very much by design, very much about time management, racial capitalism, control of Black and brown political mobilization. I mean, those are all part of that framework. But just briefly, while I was working at Riverbend, one of the things that, again, these folks who were describing medical intentional misdiagnosis, what it did, it was a spotlight in the carceral system on something. But if you kind of like see what the light is showing you in that spotlight, you start to see those carceral logics, those kind of punitive logics, those repressive logics now across every medical institution. In that sense, the kind of punitive aims of whether or not someone's following up with a treatment regimen and whether they need to be, I know you have some examples there too, right? So how it is that, say, for example, a clinician is now responding to a so-called non-compliant patient, all of those things I think are embedded in that. So yes, absolutely.
I think even just the idea that, until very recently, and I will let you talk. Yes, ma'am. But that, a person struggling with a chronic substance abuse problem needs to be treated by a prison or a jail. And that if they are lucky enough to get into the so-called detox unit, that they'll get, you can get support to detox, but detoxing and treatment are two separate things. I used to volunteer at a women's correctional facility in DC, and with a group that did poetry workshops in the 90-day detox unit. And that was always the first, every week we went, every week there was new people. Every week they were like, why are y'all doing poetry in here? Which is an excellent question. And what I learned in listening to the person doing the workshop, who was at that point, she had been in recovery for, I think, 15 years, in part because of getting comprehensive drug and alcohol treatment, therapy, and going to a theater program that I was part of way back in the day. But she could get access to them to tell them her real story, that this 90-day situation wasn't going to do it. Because she'd done the 90-day, she'd done 90, she'd done 180, she'd done that 90-day treatment 4 or 5 times. She'd been across the street, she'd been all over the place. And what she needed was a 24-month residential program where she could have her kids with her so that she could get treatment, they could get treatment, she could go to individual therapy, she could go to group therapy, they could go to family therapy, she could get support with housing and getting back on her feet. She had been working on Congress before her addiction became such that she was unable to manage her day-to-day life and pay her bills. But she was not a woman who had no skills. She had incredible skills, right? She was expert at avoiding social workers. She could find crack in DC all hours of the day and night, right? She had done sex work. She was genius, and she'd managed. Her thing was she was not going to go to treatment and leave her kids to the foster care system. That was not health or healing for this woman. But my point was that she now could go back to the facility under the pretext of a poetry program and tell them the truth, that this 90-day stuff was not going to save their lives. It was a okay beginning, because the couple, jail staff who ran the program had minimal training. They might have been very well intentioned, but they had minimal training. They were not counselors. They were not. They did not really know what these women needed, but they were authorized, and they were and to so-called educate them about what they needed to do to get their lives together. And they did provide, yes, a minimalistic support with all the trappings of the penal system, that if you didn't do XYZ, then you were going to get thrown back into the general population and get no support. And so it was always a punitive model. So, and I think what you're alluding to is that there's this expectation too often baked into our healthcare system that people who are in need of care, they don't deserve care. They need to be punished for the conditions that they find themselves faced with, instead of being valued and treated with dignity. Yeah, ma'am. Yep, I'm done.
So in regard to your question about this clip and the amassing of police around the hospital, we had breached the system. And that's part of the reason why we did it, to flamboyantly show them that if you don't change, if you don't meet the demands of the community, not our demands, but the demands of the community, we are going to take it further. The community won't just be the young lords and the Black Panthers. It'd be the community coming in here and demanding change. And we're going to get to that question a little bit later. But in fact, police brutality, the intersection of police brutality is a George Floyd situation, where this man has his knee on the neck of a man for 10 minutes almost. I'm a little exaggerating, but almost 10 minutes. And with the refusal to allow a healthcare professional to come in and look. But when people are requesting, look, you're going to kill this man. And that's what police brutality looks like, in fact. And that's where the question of healthcare and brutality and violence toward the community becomes so clear. So yes, we wanted to get in there and prove that it could be breached, and that we could demand that you move out and let some people that know how to deliver health care do the job. So
that was a great question. Are there any others boiling in the room?
Can I actually, I really appreciate that question. I want to jump in as well. I think before my current job, I've worked in a number of prisons. And I think when you work in a prison, you recognize what you're signing up to do. You know you're going to work in a prison. And I think that a lot of people who are working in other settings aren't fully aware of the way in which the carceral mindset actually pervades other spaces that are not explicitly carceral. And I think medicine is one of those spaces, to your point. And I think that there's a number of different ways in which I've seen that. And I think, again, it speaks to our project of how do we create a liberated space? How do we create a space of healing? And I think the first is naming that medicine can be a carceral place. And my patients teach me everything. I did go to med school. My patients teach me everything. And I think, to your point earlier, I teach my students, the patient is the expert in themselves. You are blessed to get to know about them. When they tell you something, believe it. And this is one area where this has been true. My patients, share that the way in which the lights flicker in clinic, the way in which the door clicks shut, the way in which chairs are set up potentially with no wall behind you, so you don't know who's behind you, you can't see who's coming. All of those really mimic and reflect the feeling of incarceration. And I think I never fully recognized until I was in a space where I could hear from patients, why is it hard to come to clinic? Why is coming to this place where I genuinely want to heal you, I genuinely care about you, and why is it so hard to come into this space? And I think the visceral experience of it, in addition to the punitive ways in which we do practice, and I think that there's unfortunately many examples of that, and I think nationally we're really grappling with how do we care for people who use substances in the hospital. I think this is a really important example of the way in which the carceral state and punitive approaches have really been prioritized over patient care and, again, healing. And for many hospitals, when somebody uses drugs in the hospital, the response is that security gets called.
And you don't mean doctors and nurses. You don't mean staff. You mean
using
patients.
drugs?
Yeah.
No, I mean patients using drugs.
Patients.
Yes, thank you.
Patients.
Thank you. Fair point, though. Thank you for your clarification.
I just want to be clear. You mean patients using drugs.
Is it important? Yeah. And I think, the first layer is increasingly we have data that demonstrates that when people use substances in the hospital setting, they're self-treating, they're self-medicating, and there is a whole opportunity for healing that's missed. First of all, by responding to that as a clinical, psychosocial, existential space where doctors can approach, doctors and nurses can approach. But then second to that, many hospitals immediately call security. Some hospitals immediately call the police. Like it is the law in that hospital where, and the nurse who finds it, the MA who finds it, the student who finds it are required to call and report this to the police. And that's not everywhere. And there are, and actually some people in this room are some of the folks who are working really hard to get alternative ways of healing, specifically around substance use, integrated into both how we practice, but how we teach this next generation of doctors to approach these things. But I think what's important, and this is, we talked a little bit about Tuskegee when we were preparing for it, and it hasn't come up, but I think there are important ways in which the historical legacy of the violence of Western medicine pervades people's experience. You don't have to know the details of the history of Tuskegee to embody the worry about experimentation. And I think the carceral system is another example where you don't have to have been incarcerated to feel like there's a punitive carceral approach to your care. There's an intergenerational embodied knowledge of how you're treated. That I think is, again, to your original point, no one's designing, there's not like a mastermind who's building this currently so that we train people in this way and that it's structured in this way. This is by design over time as a system. And I think baked into that is the feeling that we can't fix it. And I think, a lot of trainees come and say, well, what do we do? What do we do? And I remember asking my dad about capitalism when I was in 7th grade, and he gave me the Communist Manifesto. And I said, well, what do we do about capitalism? It seems pretty pervasive. And he said, it's designed to make you feel like you can't shift it. That's the whole point. And I think, that's really one of the things that we've tried to think about that I think is so valuable when you have people who are coming from different philosophical, academic thought approaches, that when we sit together, we can design something beautiful with healing at the center. And when we are able to actually have honest conversations about it, we realize that the system is not unchangeable, that it's not insurmountable, but that it's designed to, again, I keep talking about trainees because that's such an important part of where my heart is and my work is, that we can teach trainees that we can do this differently, and we can teach them, again, to have love and healing at the center and enact that and then change the system from there.
I just wanted to say that from our outline the other day, we were at this point perhaps going to turn toward talking about the perpetual roadblocks and obstacles, how we might make this model of medicine obsolete, but also what that, along the way, what does healing mean? What do we mean by healing? If we're not going to continue to uplift all the aspects of Western medical care, what are we shooting for? But I also want to attend to our audience and see if there's any questions on the floor. I see you. Yes, I see two people. Stephanie, are you standing there with a question? Okay, and then we'll go to you next. And I thought I saw someone over here as well.
Hi, I am representing a question that came in from our Zoom audience.
Oh, fabulous.
This is Alexa K, who asks, how can academic institutions better address structural violence affecting disabled people and start centering the perspectives of disabled people of color?
Maybe we can get a couple questions. Do you mind hopping up there onto the mic so the people on Zoom can also hear? Thank you.
Mine was a little bit of a wise guy question in response to your wise guy remark about the doctors and staff being on drugs in the hospital.
Hey.
But I wanted to hear Ms. Silver's response about what happened after and the escape story.
Okay, great. Thank you.
Yeah, I'm waiting for another question.
Was there another question in the room? I figure we'll just seed the conversation and go from there. But here comes Stephanie.
Zoom audience is quite hot tonight. Here's one from Holly Casino, who asks, how can we clearly assert individualizing care is okay if it doesn't fit the privileged mold? Just because the vulnerable don't fit the white mold does not make it the wrong mold. We also use one standard. Any other standard is called radical. How do we express that so that attendings teaching the structure get it? And then there's one other one here from Angela, who asks the panel their opinion on the Henrietta Lacks estate suing for compensation for alleged unauthorized and widely known sale of HeLa cells.
The HeLa
cells, especially in light of the ruling in the Moore versus Regents of the University of California that a person's discarded tissue and cells are not his or her property and can be commercialized. That's everything.
Okay, so just to run those down one more time, we had a question about what did happen after the takeover, because it is a fabulous story about how community action not only has an immediate impact on an institution, but also ignites change. The Patient's Bill of Rights being just one, but so that was one question. There was also a question, and I apologize, I'm paraphrasing, but how can we recenter the needs and I'm going to say the knowledge of disabled people in this discussion? And I'm going to loop that with the question about individualizing care. So how do we care for people who they don't fit the mold for whatever reason? or the easy ways of responding, the familiar ways of responding to people's needs. And the last one is thinking about this issue about the Henrietta Lacks case and the ruling about discarded tissues not being the property of the person from which they came. So I don't know if you want to hop into any one of them. I feel like maybe the aftermath of the takeover.
Well, before that, I want to say that because I'm 76 years old, I have done everything and been everything.
That's right.
I've been on drugs. I've been incarcerated. And I really have had a very difficult time with the experience of coming into a hospital after having been incarcerated. It's tough. The other thing is that being disabled, I'm also disabled, obviously, and I'm living in constant, excruciating pain, which is where the drugs come in. Many people are in such horrendous pain. I'm one of these people, I'm scared of it after I've been through it. So I don't want to be on opioids, but I also am happy when I am not in pain, happier when I am not in pain. And it's very small amount of time in my life when I'm not in pain right now. So I just want to say that to answer that question about being disabled and how you help people who are disabled. The other thing is the ability to navigate when you are disabled and be independent is like such an important thing. And to have access to places and things where everybody else goes is so key and so such an urgent thing, and that I think we in the medical field have to focus on that when we think of people who are disabled, the independence of disabled people, and the consistent necessity for health care from healthcare providers. And that may mean coming to someone's home at a given moment. Next question, what happened afterwards? Well, I know that you'll find out when you see Takeover that we were helped by the workers in the hospital to get out of there. The police wanted to come in there and beat us up. They wanted to kill us because we had breached something that was so sacred to them. And the only way that we could get out was at shift change. And what some wonderful doctor, radical doctor, came up with is put on these lab coats. And
Wait. Put on the what?
Lab coats.
The lab coats.
And walk out with the rest of the staff.
At shift change. That's genius.
Isn't that? That's amazing, but that's how we got out of there. I put on a nurse's outfit. They gave me a whole nurse's outfit to put on to get out, because I was acting up in there. You don't go in nobody's office and put them out and then just think you're going to walk out.
Yeah,
yes, that was me.
She threw out the head of the
Then you're not going to walk out of there. And the city had had a focus on me and other leaders. And then you'd be in a press conference and everybody knows you can't do that. But I walked out between the police cars, and the people in the community also let us into their homes, the ones that lived closest around, because they knew everybody knew what we were doing, because they saw a big sign out there. They had it all over TV, and all the TV people were like, and the young lords and panthers have taken over, and what's going to happen now? And the police are amassing, and they're going to kill them. And the mayor's office said this, all that stuff was going on. So they wanted us real bad, but we were able to get out of there. People in the community helped us. The church, St. Anselm's Church also let many of us come into their church. It was at the back of the hospital, so we got away. So that's the answer to that. And then, of course, we did get a hospital 7 years later. We got a new hospital, but, they didn't change the conditions. Conditions in Lincoln Hospital, the new Lincoln Hospital, are pretty much the same as they were in the old Lincoln Hospital. white people. And no, I just want to get this out, and then the question of Henrietta Lacks. I'm gonna let my sisters here answer that question. But what I want to say is that the whole thing is about having health care. This is what our demands are. We want the same quality health care that is given to a rich community. Rich people in the community control their institutions. They control how their hospital functions. They control everything about how they interact with the institutions in their community. And why should not poor people who are disenfranchised always also have the same interest and the same ability to control our institutions? Dr. King, before he was killed a couple of weeks, demanded a guaranteed annual income for everyone. I want to say this because this question, a financial economic issue, is another thing that is at the core of structural violence in this country, and in healthcare and in every other industry. And that is that people who don't have enough money to feed their families, to have food, clothing, and shelter, are placed in a position where they are beholden to other people to control what happens to us. So for me, the question becomes free, quality, preventive health care for all. That in fact, health care is a right, and that we have a right to demand quality health care. No question about it, bottom line. And the other thing is that our community has a right to control how the institution of health care functions in our space. So that's the answer to several of those questions.
That's right.
And I look forward to the rest of your questions. And I just, before I shut up, I just want to thank you. This has been such a lovely conversation. You sisters are just a bomb. They're so easy to talk to and so helpful. And I think we brought together like so many important questions that we can continue to discuss as we go. So thank you so much. You guys are the bomb. And thank the team. Y'all are the bomb too. You really are. I appreciate it.
I think I see Stephanie with a couple other questions for us.
Oh, we didn't finish Henrietta Lacks, Stephanie.
Can we bookmark Henrietta just for right now, since she's here
I'm sorry.
and managing the Zoom and stuff? Okay.
This one comes from Danny Ritchie. The comment about that medicine can be a carceral space is a profound statement. But is it not all a replication of punitive social control that is at all levels of our society? We are a punitive culture. Is it not all about power and control? Please talk about power and control and how it's pervasive, including in healthcare.
Let's keep doing that. Yeah. Yes, absolutely. I think I can't go in every order, but I'm trying to connect the thoughts. So I'll try to get around to some of the things. So I think the question about focusing on disabled people of color is really important, because one of the things that does, and I think, and I appreciate you sharing also a bit about your life and thinking about your relationship to also the disability. And I think because part of what now I've reframed, so disability studies itself felt very white for most of my life. Disability rights, disability studies was something that I did not see in the spaces that I understood and when I grew up. And so but that's not despite the fact that I have multi-generational blindness in my family. We have caregivers who were charged with caring for loved ones, that we lived with people who were, my grandfather could read Braille. I mean, things like that were clearly by all legal categories and governmental categories of disability. But a politic about disability was not something that was the conversation. It was more, there was almost a protectiveness about not wanting to be called disabled, because that could have been used against or weaponized, I think, in a way that would have denied somebody dignity, and I understand that. I know that that's an internalized ableism. I'm not under an illusion about that, but I also think, coming from Black and brown communities, that disability will look differently depending on how it's being manifested. And I think the reason that's important here is, and I appreciate this question, is because we don't frame drug use and alcoholism as a disability. And I think that, given the way that health discourses are now starting to circulate about, everyone says addiction's a health concern. I say, well, yes. But if we actually took a politic on this about as disability, then that's a movement, right? That's actually a way of trying to reframe what disability looks like. Trauma and living through trauma is disabilizing, right? It's debilitating. It is something that leads, so people who undergo intergenerational violence, interpersonal violence, are leading lives that are marked by disability, marked by mental health needs, marked by unmet mental health needs, right? That's why we see so much, the diagnoses of mental health conditions when people become incarcerated or brought into, survivors' spaces and so on. And so again, we see those things, they look differently when they come from within Black and brown communities and other marginalized communities. And so I think that kind of goes back to something you mentioned, Catherine, about, if we think that patients themselves are experts on their own experience, and that includes understanding how things like access, spaces, resource, trauma, those things show up now in the narratives of those who have been now living under systems of oppression, right? That itself is something that is now leading to further effects. And so I think those things are intimately connected. And I kind of want to try to thread this into the individualized care question, because that's, I think, a really interesting one. Because I think maybe another extreme of that is also precision medicine, this very hyper-specialized medicine, which I think, in a sense, also forgets that, for example, if genetic information is, as you were describing that, privileged white folks who get to have access, or privileged rich folks who get to have access to precision medicine that is now doing the kind of genetic screenings that then shape their healthcare, they're doing great with that, I guess, maybe. But for folks who have had their genetic information, like Henrietta Lacks and her family, weaponized against them, exploited against them, that is not something that, it's not just a neutral medical technology, right? And so the other cases here that show up, for example, with genetic, the use of human biospecimens is also things like, again, indigenous communities who have had their own genetic information used to weaponize against them to deny their land claims. And so Havasupai case in 2010 was against Arizona Board of Regents said, you cannot, without our community consent, use our genetic information for screening things like schizophrenia, alcoholism, and the so-called geographic origins of this community. Because again, that genetic information is not now used to their benefit. It can actually very significantly be used to a community's detriment. Criminalize, exactly. And so again, and then I also want to push, I think I echo 100% free, accessible healthcare, quality healthcare. But I also want to share that I've now had the opportunity to teach in Canada and to teach in Canadian institutions. And what you see, so again, my first thought was, I said, well, what would this look like now under the provincial models of healthcare in Canadian institutions, right? And so I was in Ontario. I'm working with students there, some of whom are doing law, some of whom are doing neuroethics, some of whom are doing kind of pre-med stuff, and working with other activists and organizers there. And what you see is actually that, unfortunately, and this sets the bar a little bit higher, that the free line isn't high enough. Right? The community control line, the community responsiveness line, the the broader vision is one that's going to take us beyond. Free is a necessity. That's the moral minimum. Free is a moral minimum. But beyond that, we've got to now continue on with the points you were mentioning earlier, Cleo, about the kinds of well-being and the kinds of resources within communities to thrive. Right? Those are the things that are that healthcare and resources are now in people's communities, that there are experts who are trained within communities, so it's not outsiders coming in, that it's actually people being empowered and enabled within their communities to be healers, to be responsive to trauma, to not call the police when it's something that is now going to lead to further detriment and harm in a community. So I think, again, that the what I've learned from at least the Ontarian context is that, free government-provided healthcare is a first step, and it's an important step here, absolutely. But we can also think, and I know that we are collectively thinking beyond that. So I just wanted to add that piece. Thank
Free
you.
is the floor.
Yes.
It is not the ceiling. That is the floor. Yes. Quality, accessible. Yeah. Okay. So, what are some of the barriers or obstacles that people are facing? What can people do? Folks in the audience today, folks online, what can people do right now? If they walked, it was one thing that you want people to know walking out of here that they could do, or a couple things. Is there one? I mean, maybe that's two. That's the floor again, but not the ceiling.
Organize yourselves. I think that is one of the key questions, and one of the key answers to the question is unity. And we never could have been able to pull off this stuff without having a tremendous unity and trust in each other. That, number one, somebody wasn't going to run out and tell on us before we could get the job done. And number two, that we knew that we had each other's backs. And number three, to think carefully and plan carefully before you take action. And number four, know only what the community tells you, what your community locally tells you their needs are. Not what you're thinking they might be, but in fact, delving deep enough into the community to feel what it is that their needs are. So those are my answers to some of that question, and of course,
I think some of the answer to the question also gets back to Dr. Ritchie's point from Zoom about power and control, and I think that that's such an important aspect of this conversation, because I think we've talked about this. There's a really, really important set of expertise, series of different types of knowledge that are deprioritized in how the healthcare system is set up, and also deprioritized in the individual relationships. And I think that it's absolutely about the locus of power and control, and that is an unnecessary yet current version of it. And I think to actually answer like a series of the questions that sort of came in about, how do we center more individualized care? How do we think about, doing things differently? And I think the knowledge is in the community. Like, we talk to the community that we serve. We have there be an integrated relationship such that there's not this we and then the them. And I think, so often the conversations end up coming down to money, right? That is so often, the what we hear is, well, the clinic's losing money, the hospital's losing money, this is really expensive. That's a great idea. And how do you make it work? How are we going to bill for that? And that is one option for the conversation, but it's not actually the only option. How much debt is this country in right now? Like,
billions,
how many?
billions.
Yeah, right. We're in debt. And I think we prioritize, many healthcare systems after COVID, many were in debt before, many continue to be in debt afterwards. And so I never fully understand the argument behind having the finances be the primary driver of the conversation when human life, human capital, human experience, human soul, if we might go there, is another important form of capital that can be the center of the conversation. And I think, one thing that we can do is have uncomfortable conversations and ask the folks that are currently in power, why does the conversation have to be centered around money? Why does it actually have to be about billing? I think once we get our nationalized healthcare plan that's all free, we're going to continue the conversations around equity, because I think we're not going to just snap into it. But I think currently right now we have uncomfortable conversations that I'm hoping that this has started, but that we truly value various forms of expertise and don't prioritize and give undue control and power to certain forms of expertise and knowledge that have done damage.
I just realized I was thinking about, there's been a recent case in I don't know if it's the New York Times or the Boston Globe, but about healthcare systems that have been taking money for the federal government under the pretext of providing services to indigent, low-income people, but not actually providing that care. So I think there's also a big opportunity to really scrutinize those and push back about those arguments about the costs. I mean, costs are outrageous, but it's also, someone sets those bills. Someone, decides not to put care to the people for whom the money is intended, and instead puts it to something else. Right? We act like Brett Favre, and we build a football field or volleyball or whatever under the pretext of raising money for low-income children, and then get indignant when we're found out. I mean, I think that happens, unfortunately, all the time. And Brown is definitely responsible and part of that network. The community people here are constantly demanding that Brown live up to its responsibility of its nonprofit charter status, which is to provide quality care to the indigent, the poor of this community. And anybody who has ever gone to the healthcare centers in the city on this side, so in Providence versus going to East Providence, can bear witness to the disparities in care. And and we're all in need. We're all in need. But there's these, I'm sorry, I won't say more. We only have 2 minutes, so.
Oh, no. Just a tiny example that has become a huge example is that when we demanded, and when the Black Panther Party started to question why children were hungry and why they could not be fed, and the need for the government to feed children, they said it cannot be done. We cannot feed everybody in the country. We cannot feed all these children. So we started the free breakfast program, and we proved in 41 cities that you could feed children. And that program is now a universal program in the United States. Every child in the United States is now eligible to have free breakfast and free lunch. So the financial question really is a question of the resources. And thank you so much for saying that, both of you, that it is a question of how the resources are used and who has access to the resources and how they use them in which community. So
we could come up with all that PPE money and fund billions of dollars to the wars in Ukraine and other spaces. And I'm not trying to say that these are not important initiatives, but lo and behold, you can find money when it becomes a priority. And certainly our budgets represent our values. I want to just take this time to thank the panelists once again. Please join me in thanking them for this fabulous